Hello, my name is Joey Franchini. I'm a student physical therapist at the University of St. Augustine. What's your name?
Hello, my name is Susan.
Susan. What's your last name, Susan?
Sorry?
What's your last name, Susan?
Stevens.
Susan Stevens. How old are you?
I'm 48.
48. Okay. What brings you in here?
I had a bunionectomy 6 weeks ago, and I'm just having some pain in my foot.
Bunionectomy. You said 6 weeks ago?
Yeah.
Okay. And you're having pain in your foot. All right. How would you grade your pain? From 0 is not there, 1 is just barely there, 10 is so bad you have to go to the hospital.
When?
Now.
Right now it's about a 2.
2 right now. Okay. What about at its worst?
6.
And at its best?
2.
2. All right. Is this your right or left foot?
Left.
Left foot. So what makes it worse?
Really when I'm walking, it's the worst. When I'm like stepping on my left foot and pushing off.
Walking, pushing off. Okay. What makes it feel better?
Resting.
Okay. Are you taking any medications at all to help with your pain at all?
No, but I take aspirin for blood pressure medication.
Aspirin for blood pressure. Is there any other medication you take?
No.
Okay. Is there any swelling or warmth?
Yeah, there's some more. And some redness and some more.
Swelling, warmth, redness. And can you point to me where you're feeling this pain in your foot? Is it like on the bottom side or the top side?
Kind of general soreness.
General soreness. Was there a certain incident where this happened? Or did it just come out of nowhere?
I had a bunionectomy 6 weeks ago.
So it was just a bunionectomy that caused this?
I was wearing a boot and using crutches until 2 days ago.
Okay, so you were wearing a boot and had crutches until 2 days ago. Until 2 days ago. All right. So, has it gotten better or worse, the same since 6 weeks ago? And I guess I should also ask, has it gotten better or worse, the same since 2 days ago as well?
I guess I can't really compare to 6 weeks ago because I was using a boot and crutches, so
Sure.
I can't really compare. I guess it's the same.
The same from a couple days ago?
Yeah.
Same from a couple days ago. All right. That's good. Is this your dominant or non-dominant foot? Are you right or left-footed?
Right foot.
Okay. Let's see. So have you ever had a previous history with your foot? I know you said you had a bunionectomy, but before that, have you had any other foot issues or knee issues or anything like that, leg issues?
No, I had surgery to remove my gallbladder, but that was 5 years ago.
Okay. I'll just write that down. You said 5 years ago?
Yeah.
Okay, and everything's fine with that?
Yep.
All right. Have you ever had imaging done by your doctor for this, or has your doctor said anything?
I mean, I saw my doctor, but I did not have any imaging done.
Okay, is there a script at all?
Yes.
What does the script say?
The script says evaluation and treatment, SP left bunionectomy.
Status post left bunionectomy. You said you're right-footed.
Sure.
So it'd be your non-dominant. Okay. You had no imaging. We covered medications, past medical history. Okay, so have you had any? Have you, have you had any family history of cancer, or you yourself have any history of cancer?
No.
Are you feeling any night sweats or a fever at all?
No.
Are you having any gastrointestinal, like stomach issues?
No.
Are you having any issues like in your saddle region with any numbness or tingling or anything like that?
No.
What about, let's see if I can think of another one. I mean, do you have any diabetes or thyroid issues I should be aware of?
No.
Okay. Is there a time of the day where your symptoms feel worse or feel better?
Just better when I'm not walking.
Okay. So what are your hobbies?
I like to scuba dive. I like to go on walks.
Scuba dive and go on walks.
Mhm.
How is it affecting your ability to do that?
I am not really doing those things.
You're not doing it, so you're not doing them at all.
Mm-mm.
Okay. Is that because it brings on your pain? Okay. What do you do for occupation?
I'm a lawyer.
A lawyer. How is this affecting you? Your occupation. How is this affecting your work?
Well, generally I'm at a desk, but I stand up a lot in the courtroom, and when I have to walk around, it hurts.
Okay. So, standing and walking hurts. Okay. Okay. And then before this, would you say that you didn't have any issues? Like, well, I was just trying to understand how functional you were before this injury. No issues at all.
No.
Okay, so now you're having these problems.
Yeah.
Are you having any problems at home, like going up and down stairs or walking around the house, or
I mean, yes,
getting
it's
in and out of the
uncomfortable to walk
bathroom?
around the house, but I'm not having any trouble.
Okay. No. What kind of house do you live in? A 1-2 story house?
1 story.
Okay. All right. Well, I'm just gonna. Or what are your goals before I summarize everything here? What are your goals for physical therapy?
I would like to be back to pain-free walking.
All right. All right. So I'm just gonna summarize some things here for you. Let me know if I misspoke or is there anything else that you would like to add that you haven't mentioned already. So you are a 48-year-old female. You're Susan Stevens. You have left foot pain. You had a bunionectomy 6 weeks ago, and you were in crutches and in a walking boot for up until 2 days ago. You like to scuba dive and go on walks, but you cannot due to pain. You are an attorney, lawyer, but you can work, but you're having pain due to standing for extended period of times. Rest makes you feel better. Walking and pushing off makes it worse.
Correct.
So you had gallbladder surgery 5 years ago, aspirin for low blood pressure. Is there anything else that you would like to let me know that we haven't covered already?
It says pain withstanding if weight put through left LE for greater than 15 minutes.
So greater than 15 minutes of standing causes symptoms. All right. All right, so I think that there might be a tendinopathy, maybe in the posterior aspect of the toe, or maybe the big toe, because of the bunionectomy. There could have been some swelling in the area following, and then following immobilization after that. And now that the boot is off, she has more mobility, and the tendon hasn't been used to extending and contracting, and that could cause the redness and warmth as well. The redness and warmth also makes me think that it's something a little more recent. Nothing really wrong with the bunionectomy, because it wouldn't be red and warm, and there might be some swelling, but not red and warmth. So I'm thinking maybe tendinopathy of maybe the flexor hallucis longus. So I'm going to be checking that out. And then another idea of mine would probably be maybe first MTP or IP, first IP, hypomobility or hypermobility. And I guess maybe I can also check the tarsal as well. So I'm thinking either hypermobility, hypomobility of the first CMC and or IP and or tarsal bone, or tendinopathy of the flexor hallucis longus. The exam steps I would like to perform here are going to be PFC. Let's go with I'm going to want to do let's go with AROM. I want to go with PROM classical and PROM accessory. Just determine the hypo or hypermobility, and definitely want to determine the tendinopathy. I'm going to want to do MSTT, followed by potentially MLT and or MMT, which could be deferred. MLT is deferred with weak and painful or weak and painless MSTT, while MMT is deferred with anything regarding pain with MSTT. MLT would be okay with moving forward if it was pain and strong MSTT. So I guess I'll finish it off with a palpation for tenderness. So I've got 7 here. It's quite a bit. I don't know if I'd go through with 7. But I'd say probably since I already know that there's redness, warmth, and swelling, I could probably cancel out the palpation for condition. Considering that there is possible tendinopathy, I could 5 and 6 MLT and MMT could be end up being eliminated at that point, leaving me with AROM, PROM classical, PROM accessory, MSTT, and PFT. So we'll see how this goes.
I can keep myself then?
All right, I am going to need you to lay. You know what? I'm going to do a screen really quick. So I'm going to have you just sit on the edge of the table here. We'll get our technician out of the way. So if you could just kind of bring your toes up and down on your right and left foot, please. On your right and left foot, please. Thank you. And if you could bring your foot up and down like this on both sides. Can you bring your foot up and down on both sides, please? Can you bring it in and out like that? Both sides. Let me know if there's any pain. Then if you could put a little overpressure maybe. How about that? So just bring it down, put a little overpressure there, up, a little overpressure there. Bring your toe down, and move down. Okay. A little overpressure. Up. Down. Straighten the knee. Back. Back the knee. Good. Out. Out. Okay. Then I'm going to have you kind of extend your knee out. Both sides. Good. And have you come, there you go, bend your knee. I'm just going to provide some pressure here, just kind of resist my pressure here. Kick out. Good. Kick out. Excellent. Maybe kick in or pull in. Pull in. Excellent. Alright, so I'm going to have you I'm gonna have you pull up here with your foot. Good. Pushing my hand. Excellent. Same thing here. Up. Up. Oh, pop there, huh? I'm gonna have you. Is your left foot? I'm gonna touch your opposite foot first.
Please don't hit it.
I'm gonna ask you to take off your right sock and lay it flat on your back.
Back trees.
It's inevitable. I'm doing palpation for condition first, so I'm just using the back of my hand here. I'm just being palpating around the ankle. And then you can see if there's any excess warmth or swelling. Around the top of the foot, dorsum of the foot, minor aspect of the foot. Around the toes, front side. Looking, spreading the toes, seeing if there's any excess swelling. I do notice. I would perform this on the opposite side. If there was swelling, I'd get my tape measure and I'd measure the circumference of the toe and or foot area and compare it bilaterally. What are my palpation for condition signs?
Swelling in the first MTP plus 5.5 centimeters.
Swelling first MTP. Said 0.5 centimeters.
0.5 centimeters / moderate. And there's redness and warmth. And my
You
incision.
said 0.5 centimeters moderate?
It says 0.5 centimeters / moderate.
Oh, moderate swelling, okay.
Yes. And there's redness and warmth. And the incision is well healed.
Redness, warmth, well healed. Okay, great. So is that it for PFC? First MTP should be right here on the left side. Perfecto. I'm going to move on with my PFC. I'm going to do active range of motion. So I'm going to prop up your foot with towel. Okay, probably go through the towel if you lift up your legs for me. Good, back. Now I ask you to scooch down a little more because I want your feet off the table. Good deal.
Oh, shoot.
What? Okay, number one. So if you could bring your foot up like this. Good, then bring it down. Excellent. Bring it in, bring it out. Same thing on this side, please. Okay, excellent. I would take those motions here. So if I'm going to measure dorsiflexion, if you bring your foot all the way up, please. Grab my goniometer and do lateral malleolus in line with the in line with the fibula, then also parallel with the fifth mat. Same landmarks again for plantar flexion. Maybe bring your foot all the way down, please. Good. We'll be measuring lateral malleolus to fibula in line with the fifth mat. Again. Then I'm going to be measuring. Let's do this. I'm going to have you bring your big toe up, please. Good. We'll measure that. So I'm going to do the fulcrum is at the MTP. Moving arm is in line with the first mat, and then the stationary arm is in line with first tarsal. So say that mat, first tarsal, carpals, and hand. So then I'm going to do flexion. So I'm going to have you bend your toe down. Excellent. So I'm going to do the same thing again. Fulcrum's at the medial aspect of the MTP. Moving arm is at the in line with the first phalange, and then stationary arm is in line with the first tarsal. We're doing the same thing on the opposite side, both sides. So I've done plantar flexion, dorsiflexion, flexion and extension of the big toe. I would also bend the knee. Bend the knee. So I measured active range of motion with the knee straight, so that is good. And I'm going to bend it, so that puts the gastroc on slack. So now I'm going to be testing the soleus. So have you bring your toe up or your foot all the way up again. Good. So I'd be testing the same thing again here with the lateral malleolus, the fulcrum, in line with the fibula, and with reference to the fibular head, right over here. And then I would have the moving arm parallel with the tarsal. So, or parallel with the tarsal. So then, Aram, what are my findings for active range of motion, my fair maiden?
Just active, you don't want passive here.
I haven't done passive yet.
Okay. Great. For the ankle, with knee flexed,
Okay with knee flexed?
normal.
Okay. Knee bent?
0 degrees.
Of ankle dorsiflexion?
Sure, yeah.
Okay.
With ankle plantar flexion, normal.
Okay.
Ankle inversion, eversion, normal.
Okay.
That's on both feet. At the first MTP inflection, the left has 10 degrees. 20 degrees on the right. Okay.
Well, right down here. Move over here. Here on classical. Okay, so we're looking at toe flexion. First MTP. Okay. Okay, left is 10 degrees.
Left is 10. Flexion.
Yep.
Right is 20 degrees.
Okay. Good.
Okay. In extension, left is 10, right is 60.
Wow, 10 extension.
Right is 60.
TP extension.
Okay.
10, 60. Is there any pain at all for this?
No.
Okay.
And then at the first IP flexion, 10 degrees on the left, with pain over the EHL tendon.
First IP flexion was, say it again, just writing
10 degrees.
on the left.
Yep, 10 degrees on the left with pain over the EHL tendon.
Over extensor houses longest tendon. Okay. What about the right?
60 degrees.
Again, okay.
And then first IP extension, 0 degrees in both.
No pain at all for extension. Okay. So now I'm gonna do passive range of motion classical. Alright, so moving on. Classical. So since the A-round was fine with dorsiflexion, plantar flexion, inversion, knee bent, knee straight, I'm going to do I'm gonna focus on the first MTP for passive range of motion classical. So MTP and IP. So for MTP, I'm going to do here on classical. So I'm going to stabilize here and take them into all the way of flexion. Again, same going in my spherical landmarks. Medial aspect of MTP. First MTP is the fulcrum, stationary marks. I'm gonna go to IP. I'm gonna go flexion, soft end feel, extension. So for extension, I feel a hard, bony end feel. For flexion, I feel a ligamentous capsular end feel. For the first MTP, I feel a firm capsular end feel with flexion, a firm capsular end feel with extension. Do you have any pain with that?
Yes, I do.
For which one?
First MTP, flexion, and extension.
First MTP, flexion, and extension.
Mm-hmm.
First MTP, flexion, and extension. Okay, and then what is the
Pain over the MTP.
okay? What's the range of motion?
20 degrees for flexion, 15 for extension.
For MTP.
Mm-hmm.
20 and 10 with pain.
20 and 15. 20 in flexion, 15 in extension.
Okay.
Both with pain. Both with abnormal capsular end feel.
Okay. And then what about for first IP?
15 degrees in flexion and abnormal capsular end feel.
Okay. What about extension?
10 degrees normal.
Extension.
10 degrees of extension, or 0 degrees, I'm sorry. 0 degrees and normal feeling.
And the pain was located where?
At the at the pain over MTP. It says.
Pain over.
Mhm.
Okay, so that capsular end feel. So also. Okay, so now I'm gonna do pure accessory here. So I'm going to perform. So what I need you to do here is I need your foot to be like this. Move this, please. And then I need to put a mobilization wedge underneath your foot here. I guess this will have to do with my mobilization wedge. So, flip right over the mobilization wedge. Maybe they can see here if I move this. Yeah, move your leg up. That's a little better. Alright, well, I'm doing my best here. Anyways, so there's my mobilization wedge right here, this blanket. And I am going to be doing a posterior glide, plantar glide of the first MTP. I'm going to stabilize proximally, track a little bit, right down, direction of force, quality, quantities, and behavior. That's a normal capsular end feel. Any pain with that? And then extension, a dorsal glide of the first MTP. I'd say that's normal capsular end feel. Inquire for patient symptom behavior. Pain with that. Now I'm doing first IP here. So I'm going to stabilize proximally, distract a little bit, dorsal glide. Quality, quantity, symptom behavior. So normal range of motion, normal capsular end feel. Do you have any pain with that? Then plantar glide or volar glide of the first IP. Normal capsular end feel, normal range of motion. Do you have any pain with that? So that is PRM accessory for the first MTP and first IP. What would the findings be?
For accessory mobility.
Yes, madame. Accessory mobility.
Right hypomobile MTP.
Write this down here. Moving over here. Right hypomobile MTP. Foot. Okay.
Right hypomobile MTP. Why is it saying right? It shows
That might be an error.
maybe it was
First.
with dorsal plantar glide and distraction.
Sorry, I just organized this down there. What can you say that again? Dorsal glide.
Hypomobile MTP, dorsal plantar glide and distraction.
Dorsal glide, plantar glide, and distraction. And then what about the left side? Normal or nothing?
It just says right hypomobile. Like I said,
Okay, it's
I think
probably
it might be an error. Okay.
And then what about the first IP?
I don't know. It just says hypermobile first ray, dorsal glide, medial talar glide.
First ray, huh? They did tarsal glide. Huh. I would have stayed away from that. Not necessarily stayed away, but I wouldn't have done that. I didn't do that, but I will do it. I guess I probably should have done that. So keep your foot on here. Going to stabilize at the clavicular. Going to mobilize plantarly, dorsally, first ray, medially.
Uh-huh.
Okay, so you said
Hypermobile.
hypermobile?
Hypermobile.
Okay.
First ray, dorsal glide, medial talar glide.
I have lab from 8 to 5. So
Over after that.
I'm actually probably going to be here for that. So I need Bree to be my patient.
From 8 to 5?
With some intermittent breaks
Alright.
occasionally.
Why?
Yeah, why?
Because Jim's gonna make ribs, but he's gonna make enough so if Joey's gonna be here. Otherwise, we were gonna divide the ribs up and just freeze some and eat
Well,
some.
I'll be here. I'll be in lab the entire time.
He will happily eat them.
Okay, so nothing regarding the
And
IP.
Jim's suggestion
No.
was, is that when you have your test.
Yeah.
I'm sorry, sir, your insurance doesn't cover that, you have to come back next year.
Yeah. Jeez,
You're on camera, Mom.
it's alright.
Oh,
The rest of the class just heard you say that.
No.
Oh.
They didn't.
This professor's gonna give him a D.
First, this is first.
I asked the guy to come downstairs, I didn't know it was
You're
first.
fine. It's seriously, no one's gonna see this.
He's
No one's-
recording for himself to watch.
You're fine. Okay,
He's
so
recording
done.
for himself. and
P-ROM
just kidding.
classical, P-ROM accessory, MSTT now, so. Lay back, please.
I'm good,
What?
I guess.
So, now that I have you still in this position, I'm gonna have you, push, down into my hand. There. So, that's not what I want you to do. I guess I should rephrase that. I want you to match my force. okay,
Thank you.
with my 2 fingers. Good, so that's for flexion. This is for extension. Okay. Then I'm gonna have you, do, IP flexion as well. So I'll stabilize IP. If you could flex and you might push it down, or just match my resistance, you should say. Flexion. Good. Push into extension. Push your toe up. Good. So that's MSTT, the flexor
Normal.
hallucis longus, flexor hallucis brevis. That's all normal?
All ankle toe movements tested are strong and painless.
gives me my pathology.
Were you right?
So I had two ideas. One of them was right. So MSTT, all strong and painless. So also known as within normal limits. All right. So if that's the case, I suppose I'll do a mini muscle test. I don't think I need to do a mini muscle length test at that point. If it's tendinopathy, I'm gonna, I guess I'll still, I wasn't sure, I don't feel like I can do it. It's all normal, but I'm gonna do it anyways. I feel like if I don't do it, it's gonna mess up. So I'm gonna have you bring your foot down. I'm gonna do a muscle length test of the, let's get some reps in. I'll do tibialis posterior. So I'm going to stabilize tibialis posterior to plantar flexor and invert. So I'm going to dorsiflex and evert, and then I'm going to take range of motion of dorsiflexion. So I'm going to, I guess I'd also take range of motion of eversion in this scenario. So the landmarks, at least for eversion, in this scenario are in line with the tibial tuberosity. Is the stationary arm. Fulcrum is between the medial and lateral malleolus, and then the moving arm is in line with the third tarsal, third ray. So that is posterior tibialis posterior. I'm going to do tibialis anterior, which is a dorsiflexor and inverter. So I'm going to, I would have you prone. Good grief. All right, I'm going to have you on your stomach, please. Again, I'm doing everything bilaterally, so I'm testing unaffected side first. I would compare bilaterally. So I'm going to, so I said it was a dorsiflexor and inverter, so I'm going to plantar flex and evert. Why does this feel wrong? Doing it in supine would compress the muscle, which doesn't feel right. I'll have to review that. Make a note. Review equal MLTs. I'm going to do the opposite of its action, which is what MLT is. So I'm going to dorsiflex and evert. Feeling I'm supposed to do this in supine now that I got you in prone. I'd be compressing the muscle. But I would not be compressing the muscle because I'm doing the tibialis anterior. So why would I put you in prone? My dummy, go in supine, please. You going again?
I know, I'm going, I'm finishing time.
Tibialis anterior is going to be fine. I'm just testing it as a reps.
Okay.
So I'm doing tibialis anterior. You can scooch on just a little bit more. Going to stabilize outside, and plantar flex and evert. And I would be again doing, it's feeling a lot better now. Yeah. Same landmarks for dorsiflexion and plantar flexion, and then same landmarks as previously stated for eversion. Then I would do MLT of the gastroc and soleus, but I already did here on classical for that, and I also don't feel like that's related. But it's the same thing for soleus and gastroc MLT as before, where I cup the heel, stabilize proximally, and take metric measurements there, and then that's for gastroc, and then I would bend the knee, and I would do soleus that way. So what other MLT can I do? So that's what's relevant here. Well, this isn't relevant. I'm gonna do peroneals. So peroneals are plantar flexors and everters. So I'm gonna do the opposite. I'm going to dorsiflex and invert. So you should feel a stretch right back here. Do you?
Yes, I do.
So I'm going to again measure dorsiflexion and eversion, 2 volumetric measurements for that. Now to the more relevant MLTs. I'm going to do extensor hallucis longus. So I am going to, that is a dorsiflexor of the ankle and extensor of the big toe and IP joint. So I'm going to plantar flex the MTP joint and flex the IP joint. That should extend, lengthen that joint. So I'm going to take geometric measurement of plantar flexion, of MTP flexion, and IP flexion. Then I'm going to do an MLT of the flexor hallucis longus. So that attaches, that goes up from the tibia area, the lower shank, goes down behind the medial malleolus, through the tarsal tunnel, and then comes underneath the foot and attaches to the plantar aspect of the big toe. So I'm going to do the opposite. That the job of that muscle is to invert and plantarflex. So I'm going to dorsiflex and evert, while also extending first MTP and first IP. I'm going to measure the lateral or the dorsiflexion, eversion, MTP extension, and IP extension. That is all the MLTs. Is there any MLT information you can give me?
Tight gastroc.
Tight gastroc. That's it. All the things I did is just gastroc. That tells me that isn't really like a finding that is not really relevant. So tight gastroc is due to the boot and lack of immobility. So it may not have a real impact on the MTP, but I guess it could. Everything else is within normal limits. Now I'm doing MLTs. So now I'm going to have you bring your big toe up and down, please. Good. Now I'm going to have you stabilize here. If you could push your big toe into my finger, please, as hard as you can. Good. Now bring up into my finger as hard as you can. Excellent. I want to do this big toe right here. This the far aspect of your big toe. Maybe push into my hand, please. And I'll extend my hand, please. Good. Now I'm going to have you push your whole foot into my hand. Good. Now bring your whole foot up. All the way up. Now pull that. There we go. Push my hand. And have you do inversion here, so move your foot in. Good. Now hold it there. Excellent. Now go out. Excellent. I compare all of this bilaterally, all the MLTs, all the MMTs, as well as everything else that I previously said. So I've done flexor hallucis longus MMT, flexor hallucis longus MMT. I've done extensor hallucis longus MMT. I've done gastroc and gastric soleus complex MMT. I've done tibialis anterior MMT. I've done inversion MMT and eversion MMT, which would result, which would be these peroneals peroneus longus, brevis, and tertius, as well as the flexor hallucis longus that comes around the medial aspect of the toe, as well as the tibialis anterior, tibialis posterior for MMT, for inversion of the foot. So that is all the MMTs.
Okay.
So MMTs, right is all 5 out of 5. Left, tibialis anterior, and tibialis posterior are 4 out of 5 for the left side. Everywhere down. So 4 out of 5, 4 out of 5 for tibialis anterior and posterior. Weakness of the peroneals, longus, and brevis, 4 plus out of 5. 4 plus out of 5 for the peroneus, longus, brevis, and tertius. Then peroneus, tertius is 5 out of 5. Okay. Tertius is 5 out of 5. Peroneus, longus, and brevis is 4 plus out of 5. Tertius is 5 out of 5. Okay, extensor digitorum longus, extensor digitorum brevis is strong. Flexor digitorum longus, flexor digitorum brevis